Hello, everyone, and welcome to another episode on this series of what, and Why. And what, and Why is really a series dedicated to discussing amazing, pivotal publications in the area of HIV research, education, and really just shining a light on the vital contributions of women in science, researchers, clinicians doing this incredible work. So I'm your host, Toyin Nwafor. I'm an infectious disease physician, an HIV advocate, professor of medicine, pharma executive, but really in this series, our goal is really to break down silos and move beyond the firewalls that sometimes separate really incredible, important work from the people who need to hear about it and delve into it. And what we're going to do with this is just meet the people behind the work, doing this work, understand what their unmet need was that allowed them to kind of say, this is a topic we want to address. What did they do? What did they find? Why should we care? And right, you get to learn about their work. And in our show notes, we'll be able to talk about how to reach out to them, their bios, and all the other incredible work. We'll focus on one publication today, but this is just a glimpse into the incredible work they're doing. So today, I'm excited to be joined by my colleague and friend, Dr. Maranda Ward, who will share her expertise on an article called Culturally Responsive Communication, Its Conceptualization and Transferability. But before we get into the what, and why, Dr. Ward, please introduce yourself.
So thank you so much for this invitation and the platform that you've created for Black women scholars. I'll say that I definitely do think of myself as a community engaged scholar because I have been trained in sociology, anthropology, public health, education. So yes, I'm a social behavioral scientist by training, and my research really does sit at the intersection between racism, identity, stigma, and health. And so yes, I focus on HIV prevention, specifically with Black cisgender women, just because that's an identity that I hold and I don't see myself reflected back in HIV prevention messages. And so I'm going to be the one to be the advocate, to be the champion, to make sure that subgroup, that population, basically gets centered and amplified so that we can actually benefit from, prevention methods like PrEP and PEP.
Wow, that was just a glimpse into the work you do. And I know as you're doing this, just a little snippet, and I know as you're doing this work, you're bringing along and mentoring and sponsoring the next generation of scholars. Like you're in real time, amplifying their work, supporting them, which is critically important. Thank you so much for introducing yourself. So we'll delve into this paper, this culturally responsive communication, conceptualization, transferability. So, as we in research, we always talk about background, methods, results, conclusions, right? We're going to say what, and why. So can you start, Dr. Ward, with what was the unmet need? What was the problem? What was the issue that led into saying we need to do something?
Yes, so I actually was the PI on an 18-month demonstration project called 2-in-1. It was basically a model that was focusing on HIV and COVID screening and how both of them are highly stigmatized. Because on the surface you may wonder, like, HIV and COVID, that's random. Why would you pair those two? Actually, it's not very random if you think about it, right? Basically, of course, they're both viruses. They're both highly stigmatized. They both disproportionately impact the same patient populations, and that includes those, racial, ethnic, gender, sexual, minoritized populations. And so I was like, you know what? Why don't we have a conversation with clinicians? Because again, I know that one of those populations that I mentioned, often gets overlooked when we talk about HIV prevention are Black cisgender women specifically. And I will say that another population that gets overlooked are clinicians. There's this idea that, oh, well, they're experts, so like engage them in conversations around HIV and HIV stigma for what? We have to remember that, yes, clinicians are experts and they're also human. They also,
Right.
are participating in the same socialization process that we that we all undergo. So the stigma that's in the community shows right up in the clinic because again,
Wow.
clinicians also have anxieties and fears and, taboos around talking about sex. And that's actually one of the things that came from the research arm of this demonstration project, where I actually talked specifically with primary care clinicians about, you know what, let's have a conversation about the current CDC, guidelines on HIV testing, right? And we know right now those guidelines are not screening conversations, they're more about just the actual diagnostic test itself. But we need to have screening conversations to normalize sexual health as health. And so when talking with them, learned that, actually, they don't always feel comfortable talking to older, patients about sex, talking to married patients about, their sexual behaviors. And so ultimately I was like, you know what, this is a whole phenomenon here. And I feel like oftentimes we only talk about the culture of patients, but we really need to talk about the culture of clinicians, right? The culture of medicine, and then the culture of racism. And that's what culturally responsive communication is really about. It's really unpacking the ecosystem of culture, and so that we only don't narrowly focus on the culture of patients, but remove that ethnocentric lens and realize that there's many kind of sub levels to culture that we really need to reckon with, and so that this piece was an entry point into that.
Oh my gosh, that was incredible because you packed all the layers, right?
Yes.
And sometimes people are working on particular areas and not really understanding how all of these intersect. And the paper you talked about, the 211, has been so cited and reviewed, and people have leaned into it and has set the model for really screening in primary care. So that was kind of the unmet need and what led to this. So what did you
Absolutely.
do? What's the second W? What did you do?
So what I did was actually build the capacity of clinicians to rely on culturally responsive communication through a training series. So we basically brought in, so of course, remember I told you I want to center Black women. So of course I brought in Black women thought leaders to be, part of this training series. And of course we can't talk about, health disparities without talking about racism. So ultimately we kicked off the series with the Nicole Hannah-Jones, who's a racial scholar and, Pulitzer Prize winning author. And so really kind of set the tone. And let me tell you, that opened up talk about visibility, right? That really made it so that people who otherwise wouldn't think like, oh wait, I should be talking about HIV, as a PCP. Absolutely, right? There's this idea. Let me tell you, like literally, I was floored when I actually heard PCP say, like, why would I talk about PrEP? Like, shouldn't the infectious disease doc talk about that?
Disease.
That let me know that you don't understand what PrEP is, because PrEP is HIV prevention. So why would they talk to an infectious disease doctor when they don't have an infectious disease? Right? So they should be talking to you, because primary care is about prevention. Exactly. So again, it was just eye-opening to the actual type of support that clinicians need in having these conversations around, one, sex and sexuality, but then even more broadly, HIV prevention methods. And then, like I said, in a culturally responsive way, because again, not only did I talk to clinicians, but I talked to patients, that are minoritized, and they often shared how they feel profiled, basically, like, saying, if my clinician, asks me to get an HIV test, I will feel offended. And we're like, what? Why? Like, that's what they're supposed to do. Like, the CDC guidelines that they should be, posing this question. They're like, no, because I know that they didn't ask everybody. Why they ask me? And they're right. Because again, there's a very risk-based kind of profile with that, right? Where you're literally not asking everybody, actually. Why are you only asking the LGBTQ identified folks, right? So again, there's there's that stereotype, you profiling patients, like, I'm going to ask this person, but not that one. That's not how risk or exposure works, right? So again, marital status doesn't protect you, age doesn't protect you. So you should literally just be asking, the same way we've routinized, screenings for mental health and depression. Like for instance, just think about the last time you went to go see your PCP, no matter why you're there, they're going to ask you questions about depression. Exactly. Right. Because it's routinized. Right. That is what we're trying to do with sexual health, right? Ask everyone these baseline questions. Again, it normalizes it so people don't feel some type of way like, oh, you asked me. No, we asked everybody this. So you can just say that too. We asked everyone this. So they know that this is expected. Again, sexual health is health. So that's why I'm asking you about this in this health setting. And so then that way it removes the stigma and the, feeling, like I said, profile when they ultimately do decide, you know what, based on the way you answered this, you know what, I think you would be a good candidate for PrEP, or I think you would be a good candidate for HIV testing. Then when the test comes back negative, then you can be talking about, being a candidate for PrEP. So I just felt like there's just some levels, like some steps that need to happen. But
Mm-hmm.
again, really recognizing that clinicians need way more support than they're getting when it comes
Time
to,
again, yeah.
making sure they have the capacity and feel comfortable and confident to have these conversations. If you think about it, the primary care setting is riddled with like, oh, you got to screen for substance use disorder, you got to screen for depression. They got to do everything.
Yeah. They're going to
So
do the
then,
prior auth, they're going to do all
exactly.
this stuff, and
Yes.
it's a zillion
Right.
things. And,
Yes.
most clinicians, it's not part of our training. You come from a background with sociology and ethical, all of the things
Mm-hmm.
that clinicians aren't taught about how to
Right.
have these things. So you have, really understanding that until we tap into understanding the clinicians, their biases, their anxieties, and where their gaps are,
Mm-hmm.
we can't focus on just one stakeholder in the whole ecosystem.
Mm-hmm.
Wow, you already kind of started to answer the next question, which is the what did you find? One was the fact that primary care providers sometimes thought it was a remedy of infectious. What were some of the other key findings from this research?
Yeah, so they were very much aware of community, based stigma, both the clinicians and patients, but clinicians weren't really aware of the racism that patients have to navigate throughout the healthcare system. Everything from, again, which actually gets very well documented in the literature about how, patients get triaged differently, how patients actually, have coded language used in their electronic health record, right? It's just like all these different aspects of how racism gets codified in the healthcare system. They were not aware of it, but they agreed that they should be aware of it, because if they're not, then they're also going to
Then
be
make
perpetuating
it
and
a
maintaining it.
part of it.
Exactly. Yeah, so they 100% know the importance of recognizing not only their own bias, but again the way that racism has been institutionalized. It's just that it didn't come up in the discussion until I brought it up. It's kind of like, oh, that's interesting that it hasn't come up, right? Like if you think about when we start asking about barriers to care and all the things, they naming all these things on the patient side, but they don't name the structural factors, right? So that was kind of really interesting to us. Yeah, as a research team, we were looking at the literature, doing the scoping reviews, and comparing it to what kind of the themes that came
What
up in the
was
interviews. Yep.
Wow. That's amazing. And you can tell, guys, as you're listening to this, that you have to get and read this paper to actually delve into this, because this is really important work that has cross disease state learnings, right? This is
Absolutely.
not just
Absolutely.
specific. So the last part of the W's is the why. So why should we care about this kind of work? Why should somebody pick up this paper and want to seek to understand more? Why should we care about this kind of work?
Yeah, because like you said, this is definitely, even though, yes, I started this, concept of culturally responsive communication looking across, ecosystems, not just the patient, but the clinician, also the field of medicine, also, how, racism shows up in medicine. I there is like transferability, right? No matter if you're not, if you may not be coming in to have the sexual health screening, right? You may be coming in for asthma. You may be coming in to manage your diabetes. It doesn't matter. All of us are interacting interface with the healthcare system. We want to have clinicians who are empathetic, that are non-judgmental, that can respond to the many ways that culture shows up in that interaction, right? And it's definitely showing up, right? Because again, their cultural lens, your cultural lens, it's going to obviously, shape that interaction,
It
with the
does.
conversations that you're having, right? Let alone the decisions being made beyond the, that particular clinical encounter. And like I said, the ways that, also just gets codified, whether we're talking about clinical algorithms, whether we're talking about, again, just, who's eligible for a clinical trial, like all the things, right? All of that shows up. And so we just have to be, we have to recognize it. First, we have to name it. And then we can recognize it, and then we can mitigate it, right? And so, yes, I think it's so important because, I mean, obviously bias is very well studied in medicine, but I think that it extends beyond just bias, because culture we talk about, culture, everything from language to interaction to the way I make decisions, my health behavior, the ways that I just think about health, what counts as health, right? The way my own,
Mm-hmm.
um, you know my own relationship to my body, the concept of pain, all of those things are cultural related. Right? And so I think that we don't spend enough time really kind of unpacking that. When I say that, let me say, yes, there's a lot in the literature on the culture of patience, but it's only on the culture of patience. And I think that's, again, very
Right.
ethnocentric to really, it's almost kind of like there's a quote by Stephen Covey that says, we don't see the world as it is, we see the world as we
No.
are, right?
Right.
Right. So that being
Absolutely.
said, we have to recognize that, again,
Correct.
the clinical enterprise, right, the field of medicine,
Right.
there is a culture there which is typically paternalistic,
Absolutely.
where the power
Right.
always is given to the clinician alone. And it's like, no, this should be shared, right? There should be some
Shared. Right.
reciprocity. The lived experience is expertise. Like, I know my body,
Right.
right? And so
Absolutely.
again, like, so that in of itself is a culture, right? Then you
It
got the
is.
culture of the clinician, but that they don't typically have time. They don't take the time. They're not encouraged or invited to really be introspective of, what, how did I land, like, the positions that I have on health. Where did that come from? You
Where
never
did that
interrogate
come
that because
from?
you're
Yeah.
not invited to do that, right? We only
No.
expect patients to do
No.
that, but you need to
Right.
do that. So, like, if
Absolutely.
we both
Just
do
as we
that,
go into like
exactly. So
into
if
the
more clinicians
patients,
do that, they'll be more likely to empathize with the decisions
Right.
that patients make, because they understand. Well, this now I actually sat and thought with how I make decisions. Now I can
Correct.
now empathize
Correct.
with how you make your decisions,
Correct.
right? And how some things are,
Correct.
get prioritized differently because I'm focusing on the safety of my family versus, this pill you telling me to take, like, just like all the things.
Absolutely.
Yeah, yeah. So I think it's
Absolutely.
just
And
really
your
important.
field of work is so critically important, and it's becoming even more important as we have limited times with in clinical encounters. How do we
Yep.
understand that? And you can't really say shared decision making if both people coming into it are not aware of context and biases and stuff, right? You can
Right.
say it on paper. So the work is amazing. Thank you so much, Dr. Ward, for sharing. There's more in this paper. When we post this, you'll have seen there will be links to all her other incredible work. So thank you so much. Before I let you go, I'm going to have two questions for you. One is, what keeps you going in this work? You're doing a lot with current work and bringing on new researchers. So what keeps you going? And the second question is, what one piece of advice do you have for a newer clinician researcher who's trying to get into work doing
Yeah.
research?
I think that question about what keeps me going is so incredibly timely given the social political climate that we're in, right? Especially with the work that I do. You know, Obviously, if I'm going to focus on the impact of, culture, I am always going to bring a lens around, diversity, equity, inclusion, justice, anti racism. And we know that these are politically charged concepts, even though they're actual values, right? They're politically charged concepts now, where it's kind of like, oh, they're being banned, like offices are closing, we're not going to fund you, and things like that. So it's kind of like, so do I continue to stand firmly and say, no, this is what I do in times like this, where it's very clear that, you're vilified actually if you continue to stand for these values publicly. And I say I do, right? I do continue to stand for these values because, again, that's how values work, right? They don't, turn
Right.
off or off depending on who's in office. And so I would say that I know that there are other scholars, there are other practitioners, there are those who are in medical education, those who are, clinicians that feel the same way, but they may not have found their people. They may feel like they're out here on their own, like, oh wait, I do still have these values, but like, I may or may not have the institutional support, right? So I think that is, I feel like knowing that we're still out here is a really important message.
Mhm.
And the message that I would give to those who are interested in, joining, is that, what, nothing is like, all of the obstacles and, that we're facing right now, nothing's new. Meaning we've seen this before, as far as, just just the way when we think of like just blatant racism and attacks on people like who are undocumented immigrants, like we've seen all of this before, basically just an attack on our collective humanity. And so we're going to have to turn back to history of like what we've done
Mm-hmm.
before, right? When we didn't have the offices and the funding and the, like the things that we have now. What did we do before that got us here? So we're gonna have to go back and pull
Absolutely.
out our bag of tricks. Maybe some of those underground, ways that, and methods and ways of like operating and organizing that we've done before. Because it does feel daunting. It does feel like, oh, we've regressed so much, like, and we have. But I think that it's still worthwhile to be in this field, to, remain hopeful when it is, when it really does feel, like we should be in despair.
Wow. Such powerful words. Thank you so much, Miranda, Dr. Ward, for sharing with us. And it's been an absolute pleasure. Time flew by having this conversation. Thank you for the work you've done. Thank you for the work you're doing. And I know for the incredible work you're going to do with your team, with your collaborators, with your mentees. And, it was a pleasure. And I know we'll have you back again because we just have, there's so much you have to
Right,
offer.
right. I'm just getting
And
started. We
I'm
gotta come back.
very
Gotta come back.
glad. I know, I know. So thank you so much.
Of
And with
course.
that, we're going to close out.
All
Yes.
right. Thank you.
Thank you.